We are kicking off the first of what we hope to be a long-standing series where the OB-GYN, yes, this is my cute little mug, meets the
Oncologist. Look at this
yeah,
anatomically correct breast mug.
yes,
My patient made it for me.
yes,
It's
and my
amazing.
cute little yeah. So we thought it would be really fun where we would once or twice a month here on Substack, we will discuss, interesting cases that overlap our different areas of experience. And we'll maybe dive a little deeper into what we do in our short little social media clips and dive into the questions that we get from our patients, from our colleagues, and what we get DM'd a lot about, right? So thank you for joining me. And if you don't already follow Dr. Eleonora Teplinsky on Instagram and Substack, follow her. And if you don't know me and you're in her audience, come and follow me because we
Yeah.
we we both share a lot of passions, right?
And we're very aligned on the messaging and our goals and ultimately taking good care of patients.
Yeah. Yeah. And we get that things are not always clear cut. So we're going to try to tackle things where I think a lot of our colleagues get confused along the way, and patients do too. So today we're going to talk about high risk breast biopsies, right?
Mhm.
So you get that biopsy back and you don't have cancer, but you have something that raises your risk of breast cancer. So, Eleonora, tell us what are the most common high risk breast biopsy lesions that you see?
Such an important conversation because this is a confusing topic. So, some of the big high risk ones are going to be atypical hyperplasia. So, whether atypical ductal or lobular hyperplasia, and lobular carcinoma in situ or LCIS. DCIS falls into a different category, and I think we'll do a different Substack video on that. But for today, we'll talk about atypical hyperplasia and lobular carcinoma in situ. And what's really important to know about these is that they are benign but high risk lesions, meaning they increase your risk of being diagnosed with cancer in either breast in the future.
And can you just quickly explain for the audience ADH and ALH? What's more common and what are the differences between those 2?
Mhm. So think of we have our breast anatomy, I'll show you here, and we have lobules, which is where milk is made, and then the milk travels down the ducts to the nipple, areolar complex. And so lobular hyperplasia or ductal hyperplasia is where you start to see changes in the cells that line the lobules or the duct. And the cells can become weirder looking. That's the atypical part, or they can become bigger, hence that hyperplasia. So when you look at the cross section of either a duct or a lobule, you start to see that those cells don't resemble a typical lobule or a duct. Now, when you have atypical ductal hyperplasia, an important point is that generally that does need to be surgically removed or excised because there could be ductal carcinoma in situ or an invasive cancer kind of hiding where we can't see it. And there's about a 20% upgrade rate. And so for ADH, it is recommended to remove that. ALH has a very low upgrade rate, and generally we do not remove ALH. LCIS is lobular carcinoma in situ. It's kind of on that spectrum of lobular neoplasia from ALH to LCIS. And some LCIS is removed if it has more aggressive features like a pleomorphic LCIS, and sometimes we do not remove it. So those are really individual discussions with your medical team.
So I think today we're going to really focus on ADH and ALH because LCIS is an interesting topic, I think, in
Yeah.
itself. So
Yes, we
let's
can.
focus on those things. And the one last question I have for you, we are going to focus on those, but what are some other breast biopsy results that also raise risk for lifetime risk of breast cancer?
Yeah, I mean, you're going to get, when you get a breast biopsy, you can get a whole host of things that come up. And so some of the common things that we see on breast biopsies are things like fibroadenomas and radial scars, something called PASH, pseudoangiomatous stromal hyperplasia. Generally, those don't have anywhere near the same risk as your atypical hyperplasias. But I think as we think about it, generally those are monitored and you might be on a higher surveillance. So you might be getting more follow-up imaging, including MRI. But generally, as we think you have more of that higher risk, we're going to think about the atypias that are going to come up on imaging and then subsequent biopsies.
Now, what is the most common age range where you see someone with a biopsy of ADH and ALH?
I will tell you I see it all. I mean, I generally don't see it in the super young women, but we do see a wide variety, and I am seeing a lot of atypia in our 40-year-old women, 50-year-old women, and older. But, in the 40s and 50s, where we're starting to see a lot of questions emerge, right, is now you've got this higher risk lesion. And we say that atypical hyperplasia increases your breast cancer risk by about 3 to 5 times. So that's a relative risk increase. And so now women are starting to think about menopausal hormone therapy and how do they reconcile, okay, this potential increased risk of breast cancer with using menopausal hormone therapy. And I think that's where a lot of the questions are really starting to arise.
Yeah, absolutely. So before we get into using hormone therapy, let's just talk about the straightforward management. So let's
Mhm.
start with ADH. So you get a biopsy back, shows ADH. What's the next step?
So you're meeting with a breast surgeon. You're going to typically get that excised, again, to make sure we don't have an upgrade of DCIS or invasive cancer. And then you come to see me, the medical oncologist, to talk about medications. Let's talk about what those medications are in a second. ALH, again, you're going to meet with the breast surgeon. Generally, that's not going to be excised. And then again, you come to me as the medical oncologist. In terms of what we can do, have a discussion about medications to lower your risk of being diagnosed with breast cancer in the future. And these can be either tamoxifen if you're premenopausal, or an aromatase inhibitor, or tamoxifen if you're postmenopausal. I will tell you that since we had data published in 2018 for the low dose tamoxifen or baby tam, which is 5 milligrams, most of us are really using low dose tamoxifen for atypical hyperplasia rather than the full dose or an aromatase inhibitor, which just have much more side effects.
No question. Is that tamoxifen 5 milligrams a day for how many years?
So in this study, they did 5 milligrams a day for 3 years, and that's what people do. I have had some people who've offered 5 milligrams daily for 5 years, but if you're going to be a purist and go by this study, it was for 3 years.
Honors.
Are you sure?
Oh,
Okay.
you just froze for me for a second.
Oh, you
So
froze for me.
yeah, so let me just double check while I'm on here. I'm gonna switch Wi-Fi, so just hold on.
Yeah.
We may like pause for us.
Yeah.
Okay, I'm back. You can hear me?
Yes, you're a little blurry, but I think
Yeah,
then it's
you're still a little blurry for me too. So
Mhm.
hopefully when it all downloads, we'll both be crisp.
Clear.
So all right, so you said so recapping. So treatment from a medication, it's not a treatment. This is a risk reducing
Yep.
medication.
Mhm.
So tamoxifen 5 milligrams a day for 3 years.
3
So
years. Some people may do 5, but, nuanced here.
okay, but you would be happy as a medical breast
Sure.
oncologist if someone got 3 years at great. Okay. So now here's the conundrum. You just told me that the most common time for these to present really is 40s and 50s. Yes, it can happen younger, it can happen older, but you see a lot of patients with this in that time period, which is exactly the time that's colliding with perimenopausal symptoms or menopause, right?
Yep.
I think in both of our experience, we have seen that women who are premenopausal, who are not having a lot of, perimenopausal symptoms yet, right? That they actually tolerate low dose tamoxifen really, really well. Is that what you find?
Yes, most people do great on it. They actually will say, I don't even realize I'm taking something. I will say there are people that have side effects, but generally it's
Yes.
much more tolerated compared to the full dose of that 20 milligrams.
Yeah. And so I think this is one message we'd both like to get across that if you are offered reducing medication, know that actually the lower dose can be extremely well tolerated because I see a lot of patients having a knee jerk reaction of, no, I'm not going to do this. These terrible symptoms. I hear what the cancer patients go through.
Mhm.
So that may not necessarily be applicable.
Yeah.
I think the hard zone that we should talk about today is when patients are already dealing with significant perimenopausal symptoms or are already very happy on hormone replacement therapy or MHT for their menopausal symptoms.
Mhm.
And that's one of the cases I'm going to ask you about. So I'm sure you see this all the time in your clinic.
Yeah. Yeah, and
Yeah.
I think that so a couple of things. One is you don't have to take these medications. They are for risk reduction. So that's an important point. You're not treating an already diagnosed breast cancers. That's number one. Number two, I always tell people you could start and stop it. There's no contract that's binding you to it. And then number three, the lifestyle things are really foundational. So we talk a lot about how do we reduce our breast cancer risk through lifestyle, exercise, movement, what are we eating, limiting alcohol use. And I will say sometimes those were going to have such a magnitude of benefit that I do have some patients who say, I'm not going to take the tamoxifen right now. I know it's an option for me in the future. So I think it's just important to have the conversation, but you don't have to do it. This is a risk reducing measure, especially if someone is already really struggling with menopausal side effects.
Yeah, I think it's an important message that I think laying out all the options and that there's not one hard, way to go. So why don't we use this as an opportunity? I'm just going to read you something that somebody actually wrote to me um, this weekend. So I'll just
Okay.
read what she wrote. She goes,
Yeah.
please help. I was recently diagnosed with atypical ductal hyperplasia. I'm 63 and I've been on HRT since I was 55, and it has been life saving for me. So I'm going to assume she had lots of symptoms and she's really happy. I also have dense breasts. She says, HRT literally saved my life, but now the doctor is treating me as if I have a cancer diagnosis. Do the surgery to remove the area, and then they want to put me on an estrogen blocker, and they will refuse to renew my hormones. Is it possible to do the removal, stay on hormone therapy, and continued with enhanced surveillance with mammograms, MRIs? Thought.
Yeah, I think that, this is one of those things where we really have to look at the person in front of us, right? What are their symptoms? How did HRT help them in terms of what were the side effects? I don't think, and the data really does not support that you absolutely have to discontinue hormone therapy here. Again, we now know, okay, you have a slightly higher risk of developing breast cancer. And here's where I would use one of the calculators that we have that can really better quantify what that risk is. So the most commonly used calculator is the Tyrer-Cuzick model. It's widely available, and you plug in all your information. And there's some flaws to this, but you plug in your information, and it will tell you what the average lifetime risk for a woman your age is to get breast cancer, and then with your information with the atypical hyperplasia, what that's going to come out to. And then you can use that to help you make your decisions. I think that it does not need to be a blanket recommendation to come off the hormones. Again, depending on what is your individual risk, what symptoms has the HRT helped and so forth. And then, also thinking about if you're not going to come off it, making sure that we are absolutely continuing with high risk surveillance. So that's mammogram and MRI, and making sure that that stays on topic. But I don't think it's a blanket no to have to stop the hormone therapy. And that's a different conversation than we have if someone's diagnosed with a stage 3 breast cancer, right? It's very, very different.
Yeah. And so, what I like to offer these women is when we kind of lay out their options and then we're having this hormone question. In this patient's case, my perspective as a menopause specialist, I obviously, if she's made the decision that she is going to try one of these risk reducing medications, I'm here to tell her that I can help her manage her menopausal symptoms in other ways. Number one. Number two, if she decides to want to stay on hormone therapy and just go down the surgical excision and
Mhm.
enhanced surveillance, that this is where I might have a conversation with her about, well, what hormones are you on? And maybe we can, I think we both agree, and we could talk about this in a subsequent Substack recording, that there is some interesting data about Duovi because of the vasodoxifene
Yep.
component. And we hope to get a little bit more data about, hopefully soon, about how that particular form of hormone therapy may impact, maybe even lower, we don't know yet, your subsequent breast cancer risk. Um, so curious on do you have any comments on that kind of approach?
Yeah, I mean, I think that the early data that we have so far with Duobi is that, what they did is they did a 4-week window of opportunity study in patients with DCIS, which is going to be higher on that spectrum towards breast cancer risk compared to ADH. And they gave it to women and they looked at Ki-67, which is a marker of proliferation. How quickly are these cells growing? And they found that Duobi reduced that Ki-67 level. So we're not at a point yet where we can blanketly say this is an option, but I think it's a great consideration. and thinking about what hormones the patient is currently on, and theoretically do a V. Again, the way that it works, it has the beta-doxyphene, which is an anti-estrogen in the breast and uterus. So theoretically, it would work similarly to tamoxifen. We just need more data on that. But I think that's a great approach as well. And I think bottom line is that ADH, and you've taught me this actually, Corinne, is ADH may increase your risk, but there are other things that we do in our lifetime that increase risk, right? Things like drinking alcohol. So what if we stop doing that? And you kind of balance out the risk there. And so I think really understanding what level of risk you're at, what hormones you're taking, can we make tweaks? Can we manage the symptoms so that you don't feel doomed, that you have to, and that you don't feel that you feel good as you can.
And I also remind patients we can try anything and we can also untry them. So
Mhm.
you could try the risk reducing medication. We can kind of slowly remove hormone therapy. We can give you something non hormonal. We can always stick with vaginal hormones. You could try it. And if you don't like it, guess what? We can put you back on your hormone therapy. So I never want women to feel that they're, cornered into one decision. Then to end it, there's one other, is actually a patient I saw last week, and she is in the throes of perimenopause, and she's about 45 years old, and she knew she had dense breasts, so she was getting enhanced imaging, and she was actually getting breast MRIs, and she did get a diagnosis 2 years ago of atypical ductal hyperplasia. And at the time, because she was really having so much perimenopausal symptoms, she declined the medication. And when she asked her breast surgeon and the medical oncologist what she could do, they says, "Well, it's okay. I understand why you don't want to go on the medication. We'll just follow you closely. I will allow you," they said, "to go on a low dose birth control pill, but absolutely, you could never have HRT." And so, which kind of like was a confusing message to her. So she has actually been well managed on a low dose birth control pill. But when I asked her a little bit, like, did anybody talk to you about using a low dose of tamoxifen, or that at the time you may have actually been able to tolerate it? She said, actually, no. And I wish I had less fear about the risk reducing medication, because at the time her perimenopausal symptoms weren't as bad as they are now. And looking back, she's like, "Ooh, I probably could have snuck in a couple of years of that risk
Yeah.
reducing,
Mhm.
medication." So in this situation, obviously she was probably counseled a little opposite of how we might have counseled her in terms of giving her options. But she's asking me now, is like, could she at this point consider using risk reducing medication if she wanted to? So could you change your mind, and could you add it on 2 years later, 3 years later?
100%. I mean, I always talk to my patients about we are not treating something, we're reducing your risk. And this is a lifetime risk that we're reducing. And so I think for a lot of people, sometimes they are struggling with menopausal symptoms, or they're not ready, or they'll say to me, "I really want to focus on lifestyle changes right now. And I'm worried about how these medications may interact." And so we can do it later. Sometimes people will say, "I'm going to hold off right now, but if I get another biopsy that shows more ADH, or then I'm going to think about it at that point." So there's no timeline for which you have to do it. It's different when you've been diagnosed with a breast cancer. We're trying to reduce the risk of it coming back.
Yeah,
This is
that's a
really
different
trying to
topic. Yeah.
completely different. We're trying to reduce the risk that is a lifetime risk. So I don't think there is a cutoff for which we would stop. Now, granted, I recently saw a patient that had been diagnosed with atypical hyperplasia like 15 years ago. And I said, "Look, at this point, I'm not sure it makes sense. You've been doing great for 15 years." So it's really going to be individualized.
Yeah, and I also explain to patients it's just like anything else in medicine. When you are told you're a higher risk for whatever it is, whether it's for diabetes or heart disease, we give you a whole host of ways that you can reduce that risk. And people are going to choose different things. Some people are going to go on medications and say statins, and they're going to really change their lifestyle. They're going to do all of these different interventions. And so we try to like work with the patients when it comes to reducing health risks across the board. And I think that there's a strange emotional and a lot of fear when it comes to anything with risk reduction and breast cancer, right? And so I think we just want to kind of like lower the fear and make sure that women understand that they do have a lot of choices. And then I'm going to end it with this last question to you. You've got that patient who was able to get 3 years of a risk reducing medication. And perhaps she was right in her, she was a little bit younger. She had no symptoms. She really dealt well with it. But now, fast forward now, maybe it's 4 or 5 years later, right? Or whatever period of time. And she is like, now I want hormone therapy. So she did the risk reducing medication, say between 40 and 43 or 45. And now she's like, woo, menopause is kicking my butt, Dr. Teplinsky. I want to go on hormone therapy. Does going on hormone therapy now negate her risk reduction that she got from her previous
No.
medication?
No, number one, no. And I think, though, again, it comes back to, well, then what are the hormones that we're going to pick, right? So thinking back again to what that risk was, because remember that atypical hyperplasia is only one factor. There's so many other things that go into breast cancer risk. And then we might choose the Duobi. We might choose the hormones based on what her risk is. But no, it is not an absolute contraindication. But I will say, I think working with the menopause specialist here is so important, and somebody who understands it, because a lot of people will tell that person you had atypical hyperplasia, it's off limits for you. And we know that is actually not the case.
And what we do know about risk reducing medications, they are pretty long lasting. When you do it, when you take the risk reducing medication, it's not just reducing your risk in those 3 years or 5 years, it's reducing your lifetime risk, correct?
It doesn't have, it reduces that lifetime risk. Your greatest magnitude of benefit is going to be in that first decade that
First
you take
decade.
the medication. But it's, lowering your risk. And then hopefully along with that, we're making really good lifestyle changes that lower your risk. I mean, I will say that lifestyle changes and the way we live probably have more of a magnitude of benefit than the risk reducing medications in some cases. So I always think about that, right? Like, how are we moving? How are we sleeping? How are we fueling our bodies? That will help lower your risk over your lifetime.
Amazing. Well, thank you for this. So let's do a little cheers with our coffee mugs.
Okay.
Okay. So the OB-GYN meets the oncologist. This was take one of our first part of our series. So
Yeah.
hope you guys enjoyed this.
See you next time.
Have a great day.
Bye.